All right. All right, so the first thing that you need to understand, do we have a pointer or no?
Yes.
Is that all bifurcations are not equal. And the importance of that is because the treatment that we are going to do and how we are going to approach this is going to be different. So there are several types of classification of this, but we have this one that is the easiest of all. And in a way, it does, you can leave it on, let's leave the lights on. In a way, it does help you to determine. Could you leave the lights on, please? Leave the lights on. I do not want to give a lecture. A complex or not. So we have a main branch, and we have the two branches that are coming down. So whether the plaque involves the main branch, or each of these one, we will classify in a different way. All right? So if it involves the three branches, that means that it is 1, 1, 1. If it involves the main branch and the distal part of the main branch is a 1, 1, but it doesn't involve here is a 0. Okay, so very simple, but it's very important to be able to distinguish this when you do the angiography because your treatment approach will be different. This is a little more complex classification, and I do not want to go over that classification because it will complicate your life. But you have to know an additional two things. Okay? An additional two things is one of them is the angle that these side branches come out. And if you can understand if this angle is very shallow here, then it's going to be a different type of procedure because if you put a stent that it goes from here to here, you will not be able to cover this part of the vessel. You will have to put the stent very much up to be able to cover it. But when you do that, you are going to have a lot of metal in the middle of this branch. So that is why this angle is important. And the second one is, what is the length of the disease portion of this side branch? So those two things you do need to know. The angulation and what is the length of that side branch disease. Okay? Why is that? Because the longer this disease it is, the more chances you have that that side branch will need to be treated independently of the main branch. Basically, left main is a bifurcation that is a larger bifurcation than non-left main. So pretty much everything that applies to left main will apply to non-left main. Actually, left main bifurcation, because it's closer to the guiding catheter, because there is no tortuosity that you got to go through, there is not that much of the calcification that you got to go through, it is technically easier. But because of the implications that you have, if you have a complication, we need to do a very good job in the left main trunk, because if something goes wrong in the left main trunk, the patient will die, not only during the procedure, but also in the long term. So that's the reason that we emphasize so much on differentiated left main trunk bifurcation versus non-left main trunk bifurcation. But conceptually, is exactly the same. And in non-left main, you will have more challenges than in left main bifurcation, because again, left main is a 4 millimeter vessel with a 3 and a 2.5 millimeter vessel, whereas a non-left main, you have a 2.5 millimeter vessel with a 2 and a 1.5 millimeter vessel. So you are going to have much more metal and much more instruments, hardware is what we call it, in a much smaller space, okay? So an important point here is that anticoagulation is very important when you do non-left main bifurcations, because you are going to have 2 wires and sometimes 3 wires and 2 balloons and a stem body plus a balloon and 2 non-compliance balloons in the same space with a very little. So very important to have an appropriate anticoagulation. I'm not saying that in the left main you don't have to, but I'm saying that in the non-left main you do have to pay attention even more because of that. So yeah. Most of the things that were said will be the same one. So I just put this slide for one particular reason only, which is this one. Left main plaque, bifurcation plaque is distributed in this direction. You have a plaque in the opposite side of the wall in both branches and a plaque in the carina. Okay, so when somebody have a blockage in the side branch or in this one, highly likely the plaque will be on the external portion or on the carina. So when you put a stent in this main branch, this plaque that is in here will not close the branch. What it will close the branch is a shifting of the carina. So you are compressing this carina in this direction, and this is what most times will happen. So it is not the plaque that is inside that will block the artery. That is important for you to plan your procedure. So we talk about this. Bifurcation lesions increase restenosis rate, predominantly and almost always in the side branch, and that's the reason that we talk about looking at the side branch and looking at the side branch, and the side branch is what is the one that is going to determine what type of technique. Not only that, because we have a lot of metal in there, when we do 2 stents, increase stent thrombosis, we got to make sure that we do a good job, because if you have a lot of metal in a 2.5 millimeters artery, you are going to expose that patient to a lot of pro-thrombotic situation because of the metal. Again, in the left main, you have a lot of metal, but in a 4.5 millimeters vessel. Here, you have a lot of metal in 2.5. So that will be associated with clinical events, and again, optimal ostial side branch is important. So I will close this. So this is what we talk about wiring the distal one. And this is something that you have to try to do that, but there is no way that you will know for sure that you did that. But you have to apply the appropriate technique to do it. But there is not a chance in earth that you will say every time that I did cross in the distal one. You can do imaging to see where you enter in the distal or not, but in practice this is almost never done, and the only image that will give you that is OCT. IVUS will not allow you, because the definition of IVUS is not good enough, will not allow you to determine whether you enter into the distal or you did not enter into the distal. The best way to enter in the distal is passing the ostium of the side branch and coming back with the bend on the wire towards the side branch, and see whether you do have a kind of idea that you are entering into the distal portion. And if you have a mental image of the size of the side branch, and you have a mental image when you are doing it, that side branch is here, the size is here, so you will try to enter into the distal one. And the main reason for doing that, it is because of the deformation of the stent. So if you see, if you enter proximally, you will see that when you put the other stent, you will have this metal into this in here. So this part you do not need to be covered. Whereas if you have the wire into the distal portion, this will make this part of the stent to go towards the right direction, and actually it can cover the osteum in a way that will probably not need to do any additional stenting. So you see the stent here is hanging because we went proximal, so there is a lot of metal hanging in there, versus if you open it with the other way, you do not have this versus here. So that is the rationale for doing that. Again, not always is possible, and you will cross whatever the wire allows you to cross, okay? So, a couple of things. We talk about wiring the main branch, wiring the other one, delivering the stent, and then rewiring into the distal one and finishing with a kissing balloon. This is something that a lot of people do. And in general, this is not what you're supposed to be doing. It is unnecessary to do this in the vast majority of these provisional stenting. In addition to that, if you put a balloon in here, and the rationale to put it in here is to make this carina better, you are going to create an injury in the side branch, okay? So if there was plaque in there, and you balloon that plaque, and if we know the mechanism of acute coronary syndrome, so what is an acute coronary syndrome? It's a plaque that you fracture, and you don't fracture actually, it breaks on its own, and it produces an acute thrombosis. Well, you are fracturing a plaque here. There is no more aggressive plaque rupture than fracturing the plaque with the balloon. So this probably is not mandatory to do it. This is another thing that we see a lot of people doing, that they put a stent, crossover, all these things, and they just say, okay, let's open the struts to have access to the side branch. And you will hear that from probably your mentors. And so they just go and put a little balloon in here, and they open the struts to get access. Again, here what happened. You didn't do kissing, so when you open the strut here, this part of the stent that was in here is shifted now to this side. The carina is shifted to this side, so the stent is not well opposed and not well deployed here, and the likelihood that you needed to do that is to improve the access in the future is probably none, because you already access it. So if you already access it today, you're going to be able to access it tomorrow. So this is not an appropriate technique to open up the strut and with a simple balloon in the side branch. If you do that, you do have to finish, you do have to do a kissing after that. So let's not talk about this. So pot, that everybody here knew what was pot before coming to this session? Who did not know what was even pot before coming to this session? All right, everybody knew what we are talking about. Okay, sure. So we talk about this and why this is so important. Because the arteries are rounded. And if you do kissing balloon, you made this stent because of the characteristics of the balloon.